There's been a lot of conversations around the good release time, the good time release, time people can take off of their sentence. That is after being sentenced. It's not being the detainee. The assault on the correction officer took place when he was a detainee. He was found guilty for the assault, and he was penalized based on that. He lost commissary days while he was a detainee. Then he was sentenced, and after he was sentenced, there was an evaluation. Should he get a good time, hours? I think it's a percentage of his time. Should he get a good time? That's when that determination was made. And we have a timeline that we're going to send to everyone after. I'll make sure Fabian get it to you. Now, in addition to that, his role of his sentence running concurrently or consecutively, concurrently mean it's all running together. His assault on the officer and his original charge that he was in for. If it runs concurrently or consecutively, if it's consecutively, means he has to do one time and then the additional time. We don't have a determination on that. That's decided by the judge to make that determination. We don't make that determination. And even if he stood in jail longer, let's say he stood in jail for 2 years, that has nothing to do with he needed help. So even if he would have got out 90 days later and stabbed 3 people, it's just as bad. The system is broken. The mental health system, handoffs, support, having enough beds for long-term care, the mindset of giving someone medication, and then once they are stabilized, then you feel they're going to be all right. That is just not true. And then when you add, and Brian, you may want to go into this, when you add the mental health problem with drug uses, that is when he left Rikers, he was stabilized. As long as he wasn't around drugs, as long as everything was all right, when he left Rikers, he was stabilized. And now he was put into a universe where it was destabilization. Why don't you talk about some of that, Brian?
Sure. Thank you, Mayor. And I'm Brian Stetton. I'm the administration's senior advisor on severe mental illness. And obviously, we are significantly limited in what we can say about the specifics of his treatment history, but we are certainly taking a very close look at every contact we had with him in the time he had been in New York, including the time he spent in the criminal justice system and at Rikers. And we're trying to draw some lessons and things we can add to the agenda we have and how we're going to really fix this really broken system that we've been tackling for a couple of years now. Some things that jump out in terms of lessons that this case brings to mind. I will say that we have a significant need for a better residential option for people coming out of our jails and our hospitals that are known to have severe mental illness and need a place to live where they are going to receive intensive mental health services and actual medical care in that interim period between their release from the jail or hospital and when we're able to get them to the ultimate goal of a permanent supportive housing unit. That's not something that's going to happen immediately upon release, but we need something better than a congregate shelter to send somebody to have a reasonable expectation that this is someone who we're going to be able to hang on to and monitor closely. And as the mayor says, someone who comes out of jail in a good place, stable, right, taking their medication, being able to detect when they're starting to drift away from that treatment and getting back maybe into substances that undermine their recovery, it really requires us to have them on the radar. And so there is a need for a robust residential option that we are working diligently to create, and it's something I expect the mayor will have more to say on in the near future. One other thing I'll add to that is that in the meantime, we do have a really useful and successful program called IMT, Intensive Mobile Treatment, where we have teams of mental health and social service professionals who, as the name implies, are mobile. They'll go and follow a person who is unsheltered to wherever we can find them to make sure that they're taking their meds and getting all the treatment and having their general needs met. And there is, I think, a need to consider whether, again, without getting into the specifics of this case, we can perhaps tweak some of the eligibility criteria to make sure that when we release people who are known to have mental health struggles from hospitals and jails, that we are routinely ensuring that we get that person assigned to an IMT team. So work's going to happen on that.
Yeah, and no. There's two other points, and Brian will be here to ask if there's more questions on this. Two other points that's very significant here. Number one, the unbelievable constant pressure of releasing people from Rikers, constant. And we have been saying you can't prematurely release people. But that noise is so loud out there. And it's ironic, some of the same people who are critiquing what we're doing right now are some of the loudest voices about open Rikers and just let everybody out. This is the byproduct of opening Rikers and just letting everybody out. This is the byproduct of it. And we've heard it constantly. Why is anybody on Rikers? No one should be on Rikers. So let's be clear on what we constantly have to fight against and say, no, we're not just letting anybody out. We got to do it correctly. Second thing is the challenge of when people who are not in a state of what we can use involuntary action, they have to agree to it. When you reach a point that and I'm giving you a hypothetical because I don't want to go into specific of the individual, but if you reach a person who has been institutional in Rikers and upon release, they've taken their medication, they're stable, and you do your exit interview and they're okay and say, listen, do you want to go into this care? And they say, no, you cannot force them. We don't have the right to force them. They don't fit the criteria that allows us to force them. And that's a real criteria. If you try to force them, now you open yourself to the litigation, and some of the people who are saying, what did we do wrong, would be suing us because we're trying to force them. So this is what I have been talking about for years, that we have a population that can't take care of themselves, and we have to take the necessary action and stop lying about it and saying they have the right to live on our streets, they have the right not to take their medication, they have the right to do whatever they want. This is the result of what I've been talking about.